All right, my name is Sandy Maxey, and I'm a registered tech and mammographer. Today, the class is going to be called Mammography Positioning Basics. So we want to talk about a lot of different things when we're talking about positioning. But first, we really need to know, do we know the breast anatomy? So the mature female breast is composed of essentially four structures: the lobules or glands, the milk ducts, the fat, and the connective tissue. And I just brought this picture up here because this is somebody who actually had a tattoo put on after having reconstructive surgery. So I thought that was pretty interesting. Here's an actual picture of the inside of the breast. So you can see where we have the fat, the nipple, the areolar, the lobes with the alveoli, the inframammary crease, mammary ducts, and also where you can see the horizontal plane of the nipple when we're trying to actually center it and put it on the image. And of course, the pectoralis muscle over the rib cage. Now, here's a side view looking at it because it's important to note where you can see the pectoralis muscle. We want to try to get that in our film, the images, really a wide superior convex when we're talking about getting it on the MLO, or on the CC view where we would like to see the pectoralis muscle at the chest wall. And one of the other things that you don't really notice is the Cooper's ligaments on looking at these, but you can actually see these on mammograms. So the reason why I want to show it to you, and I will show it to you on a real image, but also you can see the small ducts in the acini, the major ducts, the nipple, and again, where you can see the lobes. It just kind of gives you a different perspective of looking at it. So the connective tissue cannot be individually appreciated though on the mammogram except for the Cooper's ligaments. And those can be seen as little thin lines that go to the skin and the subcutaneous adipose tissue. So here we're looking at a real image. Now, not great muscle pattern on this MLO, but you can see the lymph nodes. Would you like to be able to see those? You want to be able to see through the pectoralis muscle, and you want a much better picture of the pectoralis muscle. It needs to come down to the level of the nipple. You can see the skin line. You can see the vessels because the veins running through there. The subareolar latissimus ducts, fat, Cooper's ligaments, which you can see them. The inframammary fold, which has a fold there, but we really want to open that up because occasionally there are cancers there. And also the glandular tissue, which is the white tissue you see there. So this gives you a good idea of what it looks like on digital imaging. Has really changed the way we look at mammograms because years ago we could never see all this. So here's the picture of a breast with a lot of glandular tissue. That's the radiopaque sheet or the wider or denser areas. And this consists of the blood vessels, the lymphatics, supportive and connective tissue or stroma, and various ductal structures. Hard to be able to make all that stuff out when you have this type of tissue. And sort of looking at the cloud, you can see where you can see some fat through there. On the x-ray, it looks more gray or black. But then the glandular tissue is all the white. So you can see on looking at this one, the clouds, you can see there seems to be a lot of glandular tissue if you're comparing. Now, then we have the ones that have the adipose tissue or the fat that appears as radiolucent areas on the mammogram. So that you can see, and when you look at this one, out to the side, you can see all this fat, and it still has some glandular tissue in there. But this way, the patient, and look at the inframammary folds. So we have the muscle close to the level of the nipple. You've got a good IMF where you've opened it up to be able to see it. And then good separation of the glandular tissue, the white tissue that is on the image. Now, adipose is radiolucent, and the radiographic visible densities on a mammogram are the images of the lobular elements, ducts, and fibrous connective tissue. And of course, there's on these four images, you can see how many ways you can see all of this. Now, ducts may be seen as thin linear structures emanating from the nipple, but lobulars and their ducts are often superimposed with connective tissue structures. Now, whether the mammographic appearance of the breast will appear more or less radiolucent will depend, for the most part, on the quantity of the extralobular connective tissue. Because looking at that fourth image, this patient has a lot of that extralobular connective tissue, and it's really dense to be able to see there. Same way on the third image, where you can actually see not as much fat, and you definitely don't see any retroglandular fat next to the muscle. Now, sometimes you do images and you look at it and this lady isn't working out where you think it should be, because actually your retroglandular fat on the CC should be at the chest wall. But instead we see it in the middle of her glandular tissue. And same way on the MLO, there you can see some back toward the muscle, but again, it's between in two different areas on the glandular tissue. This patient's just made this way. When she got her first mammogram, it would be kind of confusing because this isn't what you expect, so you hope that you've not missed anything. So sometimes they just don't fall into the normal pattern. Now, classifications of the breast tissue, fatty, of course, when you look at this one, to be able to send to ACR, you want it to be mostly fatty. You'll still see some very slight glandular tissue. See how you can see through the muscle, and the muscle is below the level of the nipple. Inframammary fold still has a little bit of a fold. The next one, when we're looking at that, this is your average one. Unfortunately, you can't send this one to ACR because she has about as much glandular tissue as she has fatty tissue. So this one wouldn't qualify as dense, nor would it qualify as fatty. So she's just average. But the problem with this MLO is that the nipple is not in profile and the inframammary fold is cut off. So now we've got a dense breast tissue. And when you send films to ACR, you want them to be dense, but you've still got to have that fat in there. Some people, like, especially for the very small breasted women, a lot of times will have just a completely dense breast. There won't be any retroglandular fat or fat anywhere. Those should never be sent because they don't want anything that dense. You actually have to be able to see how the breast is made up, be able to see the glandular tissue as well as the fat tissue. And this is the one I say, don't send this one to ACR, not that we would, but I'm just saying this is an image where the breast is just too dense. It has too much glandular tissue and very little of the adipose or fat, which is right along the edge of the breast. So better anatomy knowledge means better positioning, and we have to know it. If you don't know the anatomy of the breast, you're not going to get the parts on there that need to be on there. You're going to leave them off on the image. So, and of course, not every breast is the same. There's all sorts of sizes. Everyone is different. Nipples pointing where they should, some pointing laterally, some may be pointing medially. Some may have no breasts at all. And I've actually had patients tell me that their doctor said they didn't need to get one, but yet they had the nipples. They also had your tissue up in the axilla. So why would you want to leave all that off? You can still image the patient. You just have to know how to do it. So proper positioning depends on how the technologist works with the patient during the exam. This means you need to explain what's going on because you do want the patient to help you. You also need to tell them, specifics like, I need, if I need you to lean forward, I want you to lean this way. But the point is they need to cooperate. But I always tell my patients that they have control. So when it comes time for me to do compression, I need them to let me know when it's too much. Now, when it gets to the point, because most of them sometimes as soon as you start to compress, they, oh, too much, but actually it's not. And what you have to tell the patient then is I tell them our radiologist won't accept a film that has no compression, and this is considered none. So I do have to have more compression. We really want to see what's inside your breast, and we can't do that without the proper compression. And in addition, women need to cooperate because, some of them, I'm sorry, they don't cooperate. No matter what you do, you can tell them 4 or 5 times, try to put them in the position that many times. Then you may have to go get another tech because they want it over with, but they don't want to do what you're asking them to do so the mammogram can be over with. So a lot of times, it's between the patient and the tech, but we've got to have a good relationship. However, it is the mammographer's knowledge of the breast, or lack thereof, that will help or hinder her ability to achieve proper positioning. And that's the truth. If you do not know the breast well enough to know what you can move and what you can't, then you're not going to get the proper positioning. So you want to move mobile tissue toward the fixed tissue, and you want to avoid moving the compression paddle against fixed tissue. So when you're looking at this breast mobility, you can see that you can lift the breast up and get the superior tissue if you lift the inframammary fold. So what's going to happen is you're going to get the lateral and the inferior. So when we lift the patient at the inframammary fold and lift it up, you don't want to lift too high, but if you don't lift that breast, you're going to miss all your superior tissue. And then it will move from the lateral side because, I mean, anyone you can take and pull on that breast tissue as long as your arm is not straight down by your side, and you can usually pull in the lateral tissue. The problem is the fixed tissue, because medial and superior, I'm sorry, that one's not going to go anywhere unless you bring the tissue up and get the detector where it needs to. You won't get all of the medial tissue or the superior tissue. So you want to gain the patient's compliance and cooperation. Also enlist their help. When you explain the procedure to them and let them know they're going to have some control, then they are more than willing to help you. And you'd be amazed at how much more the patients will let you compress when you give them the control. Develop a method, and I always use a little humor because, you know, when patients come in to get their mammogram, if it's their first, they're extremely nervous. It's hard to even relax any part of their body. But patients who've had breast cancer, they come back every year worried that you're going to find breast cancer. So none of them, you know, they don't just come in and say, oh, well, just do it and it's easy, and they're just totally relaxed. But if you talk about something else and use a little bit of humor while you're doing it, then the patients usually will cooperate a lot better. And listen to your patients and look at their facial expressions, because, you know, I always try to tell my patient when I position you here, if I'm pinching you somewhere, please let me know. I don't want you to move and change it, but I need to readjust, because if it comes out in my image, it'll be a fold or something that the patient, the radiologist will want us to come back and take over again. So we want to try to do it right the first time. And unfortunately, a certain percentage of all patients are going to need another image, because the patients who are very small breasted, you're never going to pull in the lateral tissue. So you're going to need to do for sure XCCs laterally. But sometimes patients fit just fine and everything's good on the CC, but then they may need to do an upper and a lower MLO so that we can really get everything and compress the tissue properly. So the percentage varies because it just varies on what kind of patient you have. And the most important thing, though, is include all of the breast tissue. Now, I know we all know why we need compression, but I'm going to go back over it one more time. We want to reduce the amount of radiation absorbed by the breast. It also separates that overlapping tissue that may hide subtle abnormalities. And I've seen a lot of technologists not want to do very much compression because they don't want it, so they don't really do it that much with the patients. But if you don't explain to them that we're trying to separate the tissue, because all sorts of things can show up, which might mean that you'll have to come back and do some spot views or something if you can't really separate the tissue very well, or the radiologist may think there is something there. So it kind of, in reality, if you think about it, it's better for the patient, because if we get compression right the first time, we shouldn't have to come and repeat that. Now, I'm not saying they can't have a mass in their breast that shows up and it isn't going to go away with any kind of compression. But too many of them, that's the reason why we now have tomo, is to try to see through a lot of that dense tissue, because those people who have that, it can hide all sorts of abnormalities. Now, you can make the difference between finding or missing an early breast cancer, and we surely don't want to do that. If you leave tissue off, you're just leaving it off in the room, so we sure won't find that breast cancer. Or, you know, like if it's missing and you just got maybe just a tip of it, but you really didn't get the whole thing in there for them to be able to see it. And it also reduces the breast thickness and the motion, because just think about it, when you compress that out there, you know, a lot of patients, when you tell them to stop breathing, we've all gotten an x-ray, mostly a chest x-ray. And what do we tell you to do but take in a deep breath? The problem is, as soon as they take in that deep breath, they're going to pull superior tissue out. So don't let patients take in a deep breath. We want to reduce the breast thickness and the motion, but the motion goes hand in hand with keeping the breast taut and also making sure the patients aren't taking outrageous breaths. Now, this is just, I don't know if you've heard of the icky ball, but this is a good example. Here's where the patient just lets us get the paddle and barely touch the breast. All right, so there's a lot of stuff in there. You cannot see everything. Then we have those patients that'll let us just do minimum, which means it might come out to, you know, like 5 or 6 pounds, but unfortunately, it's still not going to separate it very well. But when you compare these two, it definitely looks a lot better. And some people, you just can't get them past the minimum. If that's the case, you need to write a note and let your radiologist know the patient would not tolerate proper compression. So, but this one gives you an idea so that you can see some of it. But as we continue to compress, you can see we have better contrast now. And the things, the images inside are really separating so that we can see them a little bit better. But we still can't really tell what all this other tissue is that's in there surrounding those balls. So your optimal compression or proper compression, you should be able to see where there are frogs and there are tadpoles. So you can see it, and if you looked at the one directly above it, you can sort of see maybe that's what it is, but if you didn't know those were frogs and tadpoles, you would have no idea. Where here you can see it a little bit better. But just think, you've got the contrast, you now have your fatty tissue in there, so you're separating the things so that we can see them a lot better. And look how much more separated it is. That gives us the opportunity to be able to find the cancers. Now here's a patient who had her mammogram done in 2015. And the CC view, it looks fine. The nipple marker, the nipple is centered, but the nipple marker's off just a little bit. But there's really no complete line of retroglandular fat behind that tissue up next to the chest wall. So then the patient comes in the next year and we bring the patient forward and get their breast tissue on there. And like last year, if she'd gotten a cancer back in this retroglandular fatty area, you wouldn't know it until this year because we got it on there. So really important to try to show the medial tissue, which if you can do that, you can usually show a little bit of the other breast. And if it's really white right there, you're usually right back to the sternalis muscle. But you want to be sure that you get it in there and that you separate it. So do you see how much more you can see on there? Really, really important. Now, of course, we're not going to have patients that fit the average profile. If we could just get into a room and do 4 quick films and let the patient go, that'd be perfect. But unfortunately, we don't have a lot of those perfect pliable breasts. So positioning is not an exact science. It's no single technique is going to work on all the patients in all situations. Because for me, like implants, I do manual technique. And then sometimes when you're really trying these small breasts, if you don't really get enough of the breast onto the detector, it can't figure out the technique very well either. So sometimes you have to change it. Sometimes basic positioning just has to be modified. I had a patient who was in a C shape. Her spine was so curved and her head looked down. So trying to get her head out of the way, much less getting the breast on the detector because she couldn't stand up. I tried sitting and everything, but I had to take quite a few more images to be able to accomplish that I really got all of the CC and the MLO on the films. So I had to take a few more images. And occasionally we just have to sort of get creative. So you want to put your skills to use because, difficult positioning, different body types, different size breasts, you got to image the entire breast. So be sure you put your skills to use. So the art of positioning the CC view. So we're going to talk about the standards for optimal positioning of the CC view. And here, we have the CCs, the right and the left. And we've got some pectoralis muscle, we've got a lot of glandular tissue, but this patient, if you can't see behind the lateral tissue, which is up by the markers, you may need to do an XCCL if you can't get it on the MLOs. So that's where I'm talking about sometimes doing additional imaging. So what does it demonstrate? Well, the anterior, central, medial, and posterior medial portions of the breast. But unfortunately, it's not very good at visualizing the lateral breast tissue, which shows the arrow over here. So if you can't see that, and especially get it all on there for the MLO, ACR says you need to take another image then because you cannot see that tissue. So I wouldn't start out doing an XCC on the person right after your CC, even though they're basically positioned almost the same except for turning the patient. Then, get your MLO and really try to pull all that tissue on there so that you can see retroglandular fat behind it. Now, we are going to visualize the superior tissue. We should visualize the posterior tissue if we lift the breasts up like we should. No excessive exaggeration. You cannot be pulling a lot of people just pull the lateral tissue so hard they can forget to keep the medial tissue on there. So you really want to bring that other breast up, the contralateral breast, and also put their sternum up against the detector, because this way you've got all the medial. And then you can pull the lateral tissue on there, which you can see for the lateral, that we have a lot more of the retroglandular fat. But if we didn't put all that on there, we would miss that portion. And what we want to do with seeing them on the images is we would like to see it in 2 views if at all possible. And preferably no skin folds. Now, a lot of patients who've lost massive weight, like 100, 200 pounds, sometimes you just almost can't get the folds out. So that may require you to take 2 cc's so that you can get the folds out in this one area where you're trying to keep the folds out, and then take the other one and remove the folds in the other area. And, you know, don't just send folds through there, because if it was minor calcifications that could possibly be needing for a biopsy for cancer, then you'd be missing something. You want to center the nipple if at all possible in a horizontal plane, have the nipple standing out there. But a lot of patients who have the fairly large breasts, you're not going to get it on the CC view, because when you have that patient lean forward and you're pulling all this breast tissue superiorly down onto the film, the nipple is more than likely going to roll under. So if you can get the nipple in profile, fine, but most of the time it will happen on the MLO. And then there is the posterior nipple line that should be 1 cm of the MLO view. I'm not going to go into that too much with the CC view, but I will discuss it when we get to the MLO, because you cannot appreciate this without seeing both of the images. And then the pectoralis muscle visualized, which you can tell on here that they did get the pectoralis muscle. If possible, but that only happens about 30 or 40% of the time. So, and some people do a lot better with that, because if you can really get the patient to relax their shoulders and lean forward and stick their booty out, I think you'll get a whole lot more. Now, you do need to ensure that any tissue that may be missed on the MLO view is going to be seen on the CC view. And what tissue would that be? The medial. So the MLO is not, we're going to go against the medial tissue where we're bringing the paddle down right against the chest wall. That's the medial tissue that doesn't want to move. So if you don't have the patient positioned properly, you're not going to get it all. And any tissue missed on the MLO, like I said, is the medial. So only chance to demonstrate as much medial tissue as possible is getting it on your CC. But so many people worry about getting the lateral tissue on the CC. We want it, but not if you're going to have to sacrifice the medial tissue. And then demonstrate, of course, as much lateral tissue as possible without any excessive exaggeration. That I see many, many times when people are really working so hard at pulling that all over there that the nipple then starts pointing medially. So the nipples tell you what you're missing. And don't do a cleavage view to get the medial tissue that you've missed. I've had some who decide they're going to get the CC view and they'll do the CC without really getting the medial at all, even on there. They'll clip it, and then they'll get the lateral tissue on there. So this way, since they don't want to have to do 4 images, they'll do a cleavage view, and the cleavage is never a CC view for the medial tissue. The only time you do a cleavage view is if there is something there that you're trying to image to see it, because maybe there's a cancer back up against there. But you cannot do it, and you can't replace the CC view with a cleavage view. Now, we don't, like if we have any deficiencies, a lot of times, if like on that very first image I showed you, we missed the posterior tissue because we didn't get the retroglandular fat, nor did we get all the superior breast tissue, because if you can't see that retroglandular fat, you're missing it. Also, when it doesn't measure within the 1 cm of the MLO, and when you have excessive exaggeration, watch the nipples, because the nipple will tell you what part of the tissue you've actually missed on there. And then again, I talked about skin folds. Please try not to have skin folds. And a lot of them happen on the lateral side, even in the cleavage area. So you really have to watch, and we'll talk about those. Now, unfortunately, I still find people who position from the lateral side. And, it's not their fault. They were actually taught that way. But you can't, there's a lot of things you can't get if you're positioning only from the lateral side. So you can't properly elevate and determine the proper elevation of the breast from the lateral side, because you can't see when you've got the breast on there whether or not you've gotten some abdomen, or you've even lifted the detector up to the height of the inframammary fold. So you want to be sure that you can see it. If you're standing on the lateral side, you cannot see anything that's happening on the medial side, nor can you make sure that you don't have a medial air gap. Now, you should be holding on to the patient with your arm around their shoulder, because if you're doing it on the medial side, there's a mammographer's gully that's just right above the clavicle that you pull on to help keep their neck out of the image. But if you're on the lateral side, you aren't going to be pulling it on the breast you're doing. So there's no way that you can possibly save that. And when patients complain about their mammogram hurting, a lot of times it's because we have half of their neck in there. You can't see if the sternum is flush. And you can't, oh, that one just went in there twice. I'm sorry, I don't know why. So we're going to talk about positioning the CC view. So we want to start out on the medial side. The feet, the patient needs to be towards the detector, meaning that it's facing it nice and straight. But when you say that, people take a step just so close to the detector, they're almost leaning their chest back because they've got so much of them underneath the detector. You want to elevate it at the IMF and elevate the detector, not as high as the IMF though. You want to be able to slide your hand out and lay the breast on there. And this way you should be able to see if you have the abdomen, if you've got any kind of medial air gap, and if you've got it laying on there right. And also if you don't really have it high enough to get all the superior tissue, you can at this point take your hand and put it over the top and lift up the detector a little bit. Have the patient take a half a step back away from the detector, and sometimes people's half a step is a baby step that doesn't go anywhere. So you really do have to have them take a step back. The patient needs to be looking at you, so their head around the face shield. And the new machines, the face shield, when you're doing the 3D, ends up getting, it's too far over, so you really can't get the patient's head around there like you could before. So it is a lot more difficult, and especially if patients have had any kind of surgeries on their neck or anything. So you want to pull them as far as you can towards you, just the head. Have the patient lean in as the breast is being placed on there with their chest forward and their hips back. And for this, I say sort of like a Betty Boop pose, because personally I think that she leans forward with her chest out and her booty back. Put the breast on the detector. Make sure your IMF is flush. You don't have abdomen. The patient's head around the side of the tube if you can, but if you're doing a 3D, you can't do that. Lateral pull to include all of the tissue, and the contralateral breast needs to be elevated and placed on the receptor, making sure the sternum is flush with the detector. But when you take the patient's hand and have them hold on to the bar, when you're getting them that close and keeping the sternum there, be careful, because a lot of breasts will touch each other, and then you're going to have that problem where breast tissue is over the cleavage view. The nipple needs to be centered if at all possible, and it should be able to be centered. It may not be horizontally perfectly plain. It might be leaning underneath or coming up a little bit. Check that medial air gap, then pull your lateral tissue as the compression is applied. Not ridiculous, but pull it in there and apply taunt compression. And the compression paddle should be flush with the chest wall, meaning you cannot put your hand behind the compression paddle. If you can put your whole hand behind there, then you don't have enough of the patient in there. So you want to make sure that you get them in there. And then remove any skin folds without removing tissue. So the finger roll, which I will demonstrate in just a few minutes, but the finger roll will show you where you roll the tissue out. You don't put your finger on there and pull the tissue out, because then you're losing breast tissue. And this is where the patient have them hold on to the bar with the opposite arm. So the arm that the breast is being done on, that arm should sort of be resting with the elbow slightly bent and resting on the detector, rather than pushing it straight down and not being able to move the lateral tissue. And then have the patient either hold on to the bar, which a lot of the bars are gone now. So I just have them rest their thumb on the detector, but outside the white line. All right, so we're gonna first start out with the tech on the medial side of the breast being imaged. So we want to be sure that we're on the medial side. Our hand is usually around their shoulder, and or at this point, if you use two hands to position, you'll have both hands and bring the breast forward. But stand on the medial side. Then their feet must be before facing towards the detector or the C-arm. So this is where, sometimes it's a little bit of a challenge if a patient is taller than you or really short and you're really tall, but you still need to have the feet facing toward the detector. The other thing is elevate the breast at the IMF. Now this is where you get a good look. You should make sure the patient doesn't have any kind of yeast infection or broken skin under there, because a lot of these pendulous breasts will have that happen. But find the inframammary fold with just lifting the breast slightly so that you can still see where the fold is. Put your hand, once you find it, underneath the breast, keep it flat, and then lift the breast, the IMF, so that you can get the superior tissue, which you can see right there. That's definitely a lot more tissue than on the previous film where we haven't really lifted it. And then we're gonna lean the patient forward and put the breast on there. Some keep their hand around their shoulder right there, but this is where I would use 2 hands to put the breast on there. And then, but some people scoop and they put the breast up that way. That's all fine. It doesn't matter. But if you lift the breast too high at IMF properly, if you lift it properly, you're going to include that superior tissue that I'm showing you up there. But if you do it too low, then you'll lose the inferior tissue and more than likely a lot of the superior tissue and get abdomen on the film. On this film, this image looks a little bit blurry, but you can see where the breast is laying on the detector. And unfortunately, you've got a lot of abdomen there because you don't have the hips back. So this is where you're pulling it on and making sure that you have it flat against there. Have the patient take a half step away from the detector, because I always try to tell the patients, I know they just lean like the Leaning Tower of Pisa, they lean. But the problem about leaning is that means the ribs are going to be right against the detector. And so if you have them bend at the waist slightly and they've taken that little step back, then you're going to try to keep the ribs away from there, which a lot of people, when they complain, that's what they're complaining about. It's hurting there, but it's because of how they're leaning onto it. So you can see if the patient doesn't really take a step here on this last image where the abdomen is underneath the detector, and I can assure you, you cannot get the superior tissue. So you want to bring their head towards the medial side or facing you, because you're on that side getting the patient. If it can go around like this face shield, it would be able to do it. But most of the time you cannot. Have the patient lean in as the breast is being placed on the receptor, reminding them again, because I'm not kidding you, as many times as you can say, I want your hips back and, you know, chest out, they will still bring their hips in and take this little step and get all comfortable. But unfortunately, they're losing it. So if their abdomen is touching the detector, you don't have their hips back. And you have to watch that constantly, because the whole time you're positioning and trying to get them on there, they're relaxing again and they have it on there. So we want to have the breast on there, but there you can't get the superior tissue. So we want to be sure we see all of it. Over here with their hips back like they should be, you can see how we're getting the superior tissue. So capture the superior tissue, that's most important. And sort of like this Betty Boop or Marilyn Monroe, I tell people, you know, when Marilyn Monroe kind of leaned forward to show her cleavage, her little hips were back. That gives us more of that upper breast tissue. There's no way you can miss it. Or some people know Betty Boop, and again, she stands with her little hips back and her chest out. So it's really important that we have our patients basically do it. Now, not a humongous bend though, because sometimes the patient completely goes in the whole top of her head and everything, and you can't get her away from the face shield or the detector. So when you're placing it on there, a lot of people scoop it and then pull the breast down. But I start with putting both hands on the breast, having them lean forward and putting the breast on there. And then I switch hands and then start to pull down on the tissue, making sure that I've got my IMF at the right direction. So some techs scoop, others follow ACR guidelines of using both hands, but whatever works for you, that's the way that you should do it. So there's nothing wrong with a scooper as long as you know your breast and you can get all the breast tissue on there. Don't forget about the mammographer's gully. This is something that, you know, if you're on the lateral side, you're not even going to get the mammographer's gully because you're over there already putting your shoulder over there, that part of their arm. So you want to be sure that you pull right above the clavicle and pull up as you're bringing the compression paddle down, because if you don't, you're going to lose this, the superior tissue. You will be able to put a hand behind the detector because you aren't getting the patient. This is with you taking your shoulder, pushing the patient forward, but also keeping some of the neck out of there. You're not going to keep the neck completely because it's all attached, but you can really pull the majority of the neck out of it and just keep the breast tissue on there. So we want to be sure we do that. The next thing is when you have brought the breast up there, check and make sure that the IMF is really flush with the detector, which you can see on this left side here. There's no folds, no creases, it's nice and flat. But when you look on the right, unfortunately you have the abdomen there. Now, be careful when you're trying to get the abdomen out of there, because an easy way to do it is to have the patients whose hips have already come back, but push their hips back you pull down on it, but you better have checked the breast first, because if you have a patient who has a yeast infection under the breast, really bad redness, and maybe even some starting to crack, you're going to tear the breast. So be careful how you do it. If you have to just lift her back up and reposition it again, making sure you don't have it on there. But a good way to do it is have them stick their hips out and then pull down really close to the breast so that it just pulls that out. But again, don't break the breast. So here's where we're trying to pull their face around the face shield, because you can see it. And of course, this is times patients, I'm not kidding you, look down in between the face shield and the paddle, and then they're taking and pulling their breast out. So I always tell patients they can't look at their breast while I'm doing this view. So here they have it with their face turned like they should be. If you can move it around, that's fine. Making sure you don't have a medial gap in the medial air gap, and that you pull the other breast on there and make sure that you have it all on there. So you're not going to get all the medial tissue though if you don't have that patient at least trying to lean toward the medial side and really pulling in their other contralateral breast. So do a lateral pull to get all the lateral tissue, but this is as you're starting compression. And here, as we're starting compression too, that hand should go to the mammographer's gully so that we have a place to hold on to it. But at the same time, your shoulder's keeping their medial breast and the other breast up there like it should, because you don't want to lose it. So you do want to pull in that tissue. Now, just to make sure you understand what I'm saying to do about it, with your arm down by your side and the hand externally rotated, grab the pectoralis muscle and the lateral portion of the breast as if you're going to position yourself. Now, you'll see it doesn't really move very well unless you've just got a good pliable breast. Now, slightly raise the arm or the elbow slightly in front of you. And when you do that, you can feel the muscle give way and flatten against the chest wall, which allows you to pull that breast tissue in. So place your arm back down by your side. So do you feel the muscle bulge and tighten? So this is how I do my patients. I tell them, I let them rest their hand on the detector, but outside the white line. They get to rest the thumb there. And then they slightly lift their elbow so that I can really pull that tissue around there. But there are some patients, especially small breasted, that I don't care what you do, you're not pulling the lateral tissue on there. So you just have to do that XCCL. So this is what I'm talking about when I say the image. So if the patient has their hand resting slightly on the detector, but not in the white lines, because you'll see their hand in, we don't want that. But make sure that you can really pull that lateral tissue on there. And the contralateral breast, people go, well, you know, they just put just a little edge of it on the side of the detector. No, you want to pull that whole breast onto the detector, making sure the sternum is flush with the receptor. Unless, and when you pull the breast, the patient should follow. So the point is, make sure that you do have the patient straight facing the detector and the sternum is flush against it. Now the other breast isn't going to just stay right up there. And if some patients' breasts actually, when you do that, will get onto the other breast. So if that's the case, I occasionally have them take their other arm, side we're not doing, and just barely press sort of on the nipple, but back just a little bit without pulling the breast away. I can still see it without a fold there. Now, you want to center the nipple. Preferably, we're talking about horizontally too, not just centering it on the detector between the white lines. But depending on when you first put the breast on there, you can see the nipple is up just a little bit. As you start to pull down the superior tissue, that one should put it, as you can see in the left image, the nipple horizontally and medial, in the center, the nipple will be centered. So just when you do those pendulous breaths though, just know that your nipple is going to go under. So you're not going to get it in that view. You're going to have to get it in your MLO view. Now, anybody can make the breast fit if you want to lose the posterior third of the breast. And that's a big positioning don't. Because I see a lot of people, you know, they'll see the breast and you look within those white lines with the light on. And then you'll see on the medial side that we're just so close, but we're probably going to get that on there. But the lateral side, it's going over the line, but we don't want to take another image. We want to do 4, which is not right, but that's what they want to do. And then they go pulling the breast tissue off, like as the compression paddle comes down, they pull on the lateral tissue to make it fit within the screen. That's an absolute no. We don't want to lose any breast tissue anywhere. Now that medial air gap that I told you about, this is where you got to really be careful about pulling underneath if there is any redness or anything. But when you do, it should flatten itself out and you should be able to see. Now, have their patients push their hips back, because guess what? By now, those hips are not back, even though that's how you lean them forward. And make sure that their abdomen isn't touching or just lightly touching, and then pull down to remove the air gap. So check under the breast, so at the very beginning when you start to do a patient, because if a patient has an infection under there or does have already, they're slightly torn or bleeding, then you need to mention it to the patients. You need to write it in your notes, because if you don't, then the problem that's going to happen is when it gets torn, they're going to blame you for it. And here's the patient where we've got the other breast up there. It's nice and flat. You can see that you're going to get the medial tissue. So here, do you think you have muscle right there? Nope. All that white stuff is just abdomen. It may be the hint of it, but nope. And then the nipple went under, see? So you don't have the nipple in profile either, which that's okay. But you want to try to make sure that you get it. The other thing is looking at this image, which you can tell this patient's had previous surgery, but you see this gray or dark area in front of this quote unquote possible muscle. Unfortunately, that isn't, it's abdomen. And people think, wow, you know, I did a good job. I got it on there. No, you didn't, because if it goes all the way medial heading toward the other breast, that's definitely not a pectoralis muscle. And then they also forgot the lateral fold to be able to get that out. So here's another one. And again, we are not talking about muscle, maybe a sliver in the middle there, but that is again abdomen. And sometimes you will get the pectoralis muscle, but because we didn't go back and check for the medial air gap, we're going to see that we have that fold right there. So really, it's not helping the radiologist see through the breast tissue very well. And it's not acceptable by ACR. So you want to be sure that you have a good cleavage, you know, but even still, when it looks like you've got it at the cleavage, you just want to double check that you don't have them. That's where I'll tell the patient, if I feel like I'm pinching you, let me know, because I do want to change it. And here's another one, nice pectoralis muscle, pulling the breast out. The nipple is basically almost centered, but again, we didn't check the medial air gap and we have a bad picture of the abdomen. And patients will tolerate it, but they're not happy with it. But that's the reason why if you watch their face, you'll notice that you are getting it. So you want to be sure that you don't get the abdomen in any of these images. Here's another one. Woo, looks like they really got a lot of pectoralis muscle there, right? No, every bit of that is your muscle, your abdomen. So you want to be sure, just to go back to it, you want to be sure that you make sure you've lifted the patient properly, got the IMF flat on the detector, where here they haven't. So pull in that lateral tissue, but this is towards the nipple as the compression is applied. The compression should start, but you're hanging on to the patient really good. You got your fingers on the mammographer's gully as you're bringing that compression down, and you're over there keeping that other breast and the sternum flush with the detector. So you do want to pull it in. Sometimes where you see the arm over there, then we may have to have them raise their elbow, which I like to anyway, because that makes it much easier to pull that tissue on there. So you really do want to have it. Now you need to apply taunt compression. And I really truly think a lot of techs miss that. They do it because, oh, that's good for the patient. Like I can kind of feel it and it presses a little bit, but I'm not worried about it. Well, no, we don't want to bring compression down till it's so tight that we're hurting the patient or the patient is crying, because definitely he'll get written up for that, because that's not supposed to happen. But everybody's tolerance of pain is a little bit different. That's where sometimes you cannot get optimal compression. But if you explain to the patient what the doctor's trying to see and what we're trying to do by spreading the tissue out, they will usually let you do better compression. But check the lateral side for tautness. So many people I see, they're over there on the medial side, so they'll just check right there. It's not going to be taunt there. If you're going to do it, it needs to be from the lateral side. So make sure that you check it over there. But the breast cannot be honkable. And by that, I mean, I heard this years ago in a seminar, and I've never forgotten it. So if you can take your hand, and I'm just kind of demonstrating, and take the front of the breast, and if you can push it together like you were pretending to be a duck basically and honk, honk. Well, if you can move the breast that way, and I'm not saying you're doing this hard, but you're doing it, then you don't have enough compression. So here on the right, this top upper picture, you can see where there's compression, and actually almost between, like at the end of that 5 for the the center cell, and here they're not even centered on the breast either. But the point is just showing you the compression, and you can start to see it. As a matter of fact, you can see a little bit of redness behind the paddle itself. So here we go again. Here's all this nice white stuff. And is that pectoralis muscle? No, it's not. It's the inframammary fold isn't flat on the detector. And then here's another one where we do have pectoralis muscle, but we've still got a little bit of a fold in the medial. We don't even have the other breast up there. I think the detector, they got right to the edge. And so then you can't really see that you have all the medial tissue on there if you can't see a little bit of the other breast. Now, of course, patients with no breast, you're not going to see the other breast up there ever. But don't forget to go back over and check the fold in the lateral side, because both of these have terrible folds that should be removed so we can see the tissue better. Now, this one again, we have, I'll go back to this other one just for a second. I'm sorry, but I want to show it to you. So these are the same patients, better compression, but you see that really dark area right in front of the pectoralis muscle. That means, they may have a little bit of abdomen in there. But you want better compression, because look at all the dense tissue on the left image, and then you look at the tissue on the right. You can see that it's separated now in some places. So if there was a mass there, and there possibly could be, then they'll see it better. Here's another one, which again, none of this is pectoralis. They didn't get the fold out on the lateral side. They even have a fold where the breast is on there. Either the patient is pulling it, or that may be a knuckle there. I don't know, but they don't have the other breast on there. But you want to have better compression, and right here, you can't see through all that tissue. But now look at the compression. On this one, you can see it. Again, there's still a fold, not right at the breast cleavage, but just right between the two. And you want really good tissue, and look at the lateral side being pulled. Plus, there's no fold on the lateral side. So which one would you rather the doctor look at to see if you had breast cancer? Absolutely, the one on the right. So better compression, very important. But don't forget those folds on the lateral side, not excluding getting the abdomen out. So the compression paddle should set flush against the chest wall. So if you're doing it like this image on the left, and I can just put my whole hand, my palm, everything. I haven't even got her close to the thing. There should be no way you should be able to put your hand back there. Now, patients who've had a neck surgery that they can't move their head closer because of the face shield, and if we remove the face shield and we get their image in it, then you have to make a note how the patient's neck, is not, she cannot move it and cannot pull forward there. But when you do get it right, then you should be able to try to put your fingers in it, but you shouldn't be able to get them in there. And then you can see on the far right where the breast is really compressed and it's up against the chest wall. So this is just to make sure, did we really get all the superior posterior tissue, and make sure that you can't get your fingers behind the paddle. So I did this because I positioned the patient, and then I thought, well, I'm going to take a Sharpie and I'm going to mark behind the patient, because this lets techs that you're teaching see how they've missed breast tissue. So, and if you do it to a patient, be sure you take alcohol and wipe that Sharpie marker off of the breast, because you don't want it on there. But if you can demonstrate it on a student or something, that would be a little easier. But you end up putting your mark. Now I'm taking the image and I'm really pulling all the breast tissue on there. I can't get any fingers behind the paddle. And good Lord, I've missed over an inch of breast tissue. So was there a cancer there? I don't know. If we left it off on the other image, it isn't going to help us. So be sure that you're getting it on there. So really important. Don't be able to put your hand behind that paddle. So look at this image. So here's a patient comes in, they don't even have the nipple in profile. And one of the big things about doing patients with small breasts is figuring out, how do you get that breast tissue on there? The first thing is don't lift the inframammary fold on somebody who doesn't have any breasts that even hang, basically. It's just there. So you can see where the inframammary fold is. At that point, bring the detector to the inframammary fold, And then when you start to pull the breast on superiorly, you're going to lift the breast tissue, hold on to it and lift the detector before the paddle. And this is what you'll get. Now, I can't even tell you how much is lost on this one. And this is just, you know, doing a repeat on this patient. So if there had been a cancer back there, we would have missed it. And everybody that you're doing, do it as if it's you, or if it's your mother or your sister, because seriously, you wouldn't want that to happen to them, right? You're going to give them the best images you can. And I know we all get rushed at our job and you get stressed out and you just have so many patients, but every patient is important. So don't forget it and treat them as if they are. Here's another one where we've got the nipple is not really in profile. And it looks like it's going up rather than going under. And of course we have nice abdomen in there. There is nothing about that that says it's the pectoralis muscle. So now we bring the patient back. We get really good pectoralis muscle. We get the nipple in profile. And then there's a little bit of a vein. It almost looks like sometimes those things fool me. And I'm thinking, man, do I have a fold there? But spreading the tissue out. And of course, these are two different machines. So one, you have much better contrast when you're looking at it and you have the proper compression. And like I said, only about 30 or 40% of the time, but that one over there, we didn't get the abdomen out. Now, I talked about that skin fold over on the lateral side. And what's important is that we really, truly take the folds out without removing any breast tissue. So this is where it starts. You cannot have complete compression. Okay, this is before the final compression because you have to be able to get your finger in there. And then you're going to turn the finger upside down. And as I do the images, you'll see the finger rolls towards the end of the paddle. And then you're going to keep rolling it till it comes outside of the paddle. So this is to show it to you again. And then you just lift your finger out. And then where you still see the little bit of the arm over here on this bottom image, then have the patient put their hand on the side of the detector with just their thumb on the outside of the white line and have them lift their elbow just a little bit and it'll remove that out of there because you also don't want that in there. So here we are. We forgot to check this one on the first view here. There's a fold in the cleavage. And why is that? Because the other breast is touching that one. So you need to make sure that you pull a little bit to keep that breast out, but don't let the patients pull it off because look at all the tissue you'll miss. And then there's still a fold on the lateral side. So patient comes back, gets it done again. This time they got their nipple in profile, but they didn't get all of the superior tissue and the retroglandular fat behind it. So, and the compression is much better. It's spaced out and you can see a lot more of the darker areas. The contrast is better. But still, the fold over on the side, I think they've removed it, but it's the edge of the skin with the exception of that one little spot right there. But you really want to try to remove it. And when you send one that's either got the shoulder, which this one has the white, really, really white over on the lateral side, then that's usually their shoulder that's in the way. So if not, it's a lot of skin. So use the spatula if you have to keep it back out of there. But do the fold. And then when the patients are really leaning in, a lot of times they'll lean forward and we got a lot of tissue on the lateral side. So be careful they don't get it. But again, on this one, we got abdomen and the pectoralis. And we also have the lateral fold. So that one, the patient, it should have been taken over because we're missing tissue over there. This one should not pass. So have the patient hold on to the bar lightly. And I put this on here because I'm telling you, patients do a death grip. Then they bring their arm down really tight and they push both breasts together. Lifting up the elbow keeps those breasts separated. But at the same time, when people hold on to the bar, what are you doing? You're tightening your muscles. So that isn't helping this image give us more breast tissue. So, you're making the other breast get into this one. So when I showed that image where the breast is touching, this is where you've got to raise the elbow and make sure it is not touching the other breast, but I'm not taking it off of the detector. So no death grips, definitely. So let the patient rest their hand down by the side and raise their elbow slightly, just making sure their thumb is on the outside of the white line because anything on the line or inside the line will show up on your image. So check for and remove any shadows from the face shoulder, earrings, and so on. So there's the corner of the one I showed you, the shoulder got in there. But if you use that spatula to keep the shoulder out of the image, and some people, I just saw someone who had didn't have a spatula in that room, so they took their ink pen and put it in there, and I'm not kidding you, it actually removed the tissue back away to be able to take the picture. So sometimes we have to come up with things. But here's one where we have an earring and glasses. I don't let people keep their glasses because their face can't be right next to the face shield. It will push them out a little bit, and we're trying to keep them in to get as much superior tissue. So be sure you take their glasses off, and glasses are expensive anyway, and I've had some fall off because the face shield or something hit it or they hit it just wrong. So you don't want to get any of those in there. And then this is where you tell the patient they cannot look down. They get their face between the face shield and the paddle itself. Well, now we've got part of their body in there, so you're definitely missing tissue. And I don't know why they do it, but they're just very interested in seeing how we spread that breast tissue out. Also, we've gotten the nose in there because it's how they lean their head and try to move it over to the side, but they keep their nose in there. So we don't want that either. And then this last one, I'm sure you don't know what it is because when I first saw it, I had no clue what it was. As a matter of fact, all the images I had seen had only shown half of it. So they hadn't done a good job of getting the muscle. But the muscle here is to the level of the nipple when you do that slight angle. And this is a heart monitor. So you never know what you're going to see in the breast. Here's another image. Now, what's wrong with this one? Well, besides having the abdomen in the image, because you can see that nice little hunk and fold, which should be removed. They did get pectoralis. But I'm sorry, the medial is clipped and the lateral is clipped. This is because somebody wanted to put this patient on the small paddle. So when you put the small paddle, it becomes a small detector. Why would you want to do that? Because now you've got to take another image over to get the medial tissue because that's the most important for the CC. And you need to do an XCC, or you could do another thing. You could get the larger paddle and then you can see everything on this patient. So this way you're not clipping the medial, you're not clipping the lateral. And the thing about these new digital machines, it really doesn't matter if you use small, and like if they're really small breasted, you want to use the small paddle for the CC view, and then if they're skinny and tall, then you'll want to use the large paddle because you're going to get more from the clavicle down to the inframammary fold, and you don't want to clip it off. And then some people fit all on one size, so it doesn't really matter, but don't sacrifice trying to not change your paddles so that you can just do the person on the size you have on there. And then you're, clipping off the patient. So really, really important. Here's a couple of views, not really good contrast on these images because I do believe that it probably needed to have a little bit better compression. You have the pectoralis muscle, and on the right side, you actually have all of the cleavage area that shows you're going on to the next breast. But on the other one, you can see there's a slight fold, so there is a little bit of abdomen in there. Because you can see the pectoralis is really just right in the center, and then this right next to the cleavage, nobody checked the medial air gap. And just to show the same patient on the lateral view, here you go, you can see nice pectoralis muscle to the level of the nipple, but the right nipple is not in profile. Did we get it on the CC view? Yes, but it looks like it's slightly pointing medial, but I believe they have all the lateral tissue on there. But as long as it's in profile in one of the views, you don't have to do another view to do it. Now, I'm not saying that's just ACR regulation, but I'm saying if your radiologist wants to see the nipple in profile and all the views, then that's what you have to do, okay? So it's according to what your radiologists want. So just looking at this one, you want to make sure that you really have good compression, and you can see on the left here that the nipple is way out and up, where on the right, the nipple is down, and you can see the tissue sort of going in that downward projection. So here's a couple of CC views where we have a cleavage view on the right that we actually have a fold and almost a fold on the left. The nipples are pointing more medially, so that's telling me that even though we've got the cleavage on there, we can see way back there that these nipples do not conform and be in the center where you think they are. You have good pectoralis muscle, but because these patients nipple went under, you can do an anterior view to show the nipple in profile, especially if there was a lot of glandular tissue around the nipple. Like on the left side, there's not, but on the right, if there was a lot more than that, you might not be able to tell really what's going on with that tissue very well. So you may want to do one just to show the nipple in profile. So this side on the left, wow, talk about some muscle, convex. This is beautiful. It's more than centered of the breast tissue that's pulled over. The nipple is out. You got a nice inframammary fold, so it's a nice job. But the patient does have some accessory breast tissue, so there's a little bit of a fold on that left MLO, but at the end, before taking the image, we went up to that side and pulled up a little bit on the tissue to try to remove the fold. Where on the right, you can see the fold stayed there, but if that patient seems to have a little bit more of that tissue there. But why is it when you take a mammogram and you look at your muscles, they're not exactly the same from the left and the right? I don't know what you do wrong one way or the other, but it's a little frustrating to me because I like for mine to look the same, but you can't have asymmetry all the time. Here's one where it's good cleavage view, a little bit of a fold on the left side, or that's either a vein, hard to tell. This patient has had surgery, so we do have the pectoralis muscle, the nipples are in profile. There's still a slight little fold on the lateral side of the left, but all in all, it's a good image. And here's that same patient, and this one, the muscles are basically symmetrical. They're both nice convex, down to the level of the nipple and just a little bit past. Has a couple of moles down here right at the IMF, so really important to mark that on there, because if it wasn't marked at the time and it's not a tomo, you would not know that that is something she has on her skin, but that's what the circle is for. And then you can see a little bit of the latissimus dorsi up there, a small V shape of it, and you can actually see the patient's lymph nodes. And that's important to see because sometimes, like they find lymphoma on the mammogram rather than the patient having been told she has it. So good muscle in the breasts are out and up, which means that the nipples are pointing out like they should, and the breast is not falling down. So here's another view of a patient with a CC view where we have pectoralis muscle on the right. I think that's just really, on the left. On the right, I think that's a little bit of the abdomen. So, but look at all the dense tissue laterally. There's no folds or anything. And the nipples really sort of seem to be centered to the breast. So that patient's breasts, either we didn't try the arm thing to try to pull more on there, or they just have all that tissue that goes back there. There's no way to change it. But hopefully on the MLOs, you'll be able to see if you have it or not. So on here, doing it on the MLO, you can see there isn't retroglandular fat back behind the right there, going all the way up to the muscle. The breast is out like it should be, compression, but the muscles, this patient you can tell is very thin because she doesn't have much at the top, and you're trying to pull that shoulder over and really pull her onto that detector. But otherwise, it's a good image. Here's an old image, and you can tell that it's old, but again, this patient, there's hardly any retroglandular fat on the right, just a little bit on the left, but all in all, it's a crappy film. But when the patient got called back, then wow, look how much tissue again is missed on the CC view if we don't pull all that tissue on there. So it's not just a matter of just pulling from superiorly if you don't have the detector the right height, if you don't have the abdomen out of the image. You want everything correct so that you can really pull it on there. Here's another one that didn't even try to pull the lateral tissue out, got a hunkin' fold in the cleavage area, right in the medial part of the breast, which of course is keeping us from being able to see it. You know it because of the black area right in front of it. But this one, if they had gotten that out and then pulled a little more from the side, now if the nipples point that way, that's a different story, but this one looks like it's purposely missing the lateral tissue. And then here's another one, which do we have pectoralis muscle? No, because we have that little black area right there. That means it's the abdomen. But the cleavage area is good, and they did the fold on the lateral side, so it looks really good. So watch the shadows. And then Walter, they're not up there anymore, because let me tell you, as time goes by and age gets you, those breasts start falling down, which of course we try not to let that happen. So checking your CC to make sure that you really have all of the tissue. Did you get all the medial tissue? Is it all visualized? No abdomen in it, no folds. Is the nipple centered on the image? And not all nipples will, like I say, if the nipples are already pointing laterally, I've done CCs that truly, truly looks like I've just done XCCM, where I got all this medial tissue and none from the lateral side. Then I do a regular XCCL, and they're marked that way. And then the nipple looks like it's in the center, because when you pull all that tissue on there, but that's how the patient was made. So not all of these fit the exact profile. So is the posterior nipple line within 1 cm of the MLO? Well, when you're just looking at this image and you see where the line on the CC goes back to the chest wall, no matter if there's muscle or not, and then the MLO, it's to the level of the muscle when you figure out the angle. If the muscle ends, then it's going to be measured back from there. So you want to double check and make sure that you do really have the 1 cm between the two. You also want to see your IMF on there. So we'll show you that when I'm talking about the MLO. And can you see the pectoralis muscle? It's nice to get it on there. Then you know you're as far back to the chest wall as you possibly can be. But there's so many patients, you cannot get them to relax enough to make all that fit in there. All right, so now our next step is to do the standards for optimal positioning of the MLO view, which is your medial lateral oblique. So, and again, we have all different sizes and shapes, but we really truly want to do a good job. And this is the one most people remember when they get a mammogram. Like you go to do another view after the CC and they go, well, I thought it was only 2, but really, as soon as you put them on for the MLO, they go, oh yeah, they'll remember that one, because that's the one they thought that you just did. So MLO views, it's really important, like I said, to get an open IMF, get nice muscle, remove any folds. And then on this one, when you see the top up here that's white on the right MLO, this one could have brought the detector down just a little bit, because really and truly, we don't have her as relaxed on there as we should be. But when you do the angle on the breast, you do have a good line that is down to the level of the nipple. So what's our expectations? Especially appreciate the areas that each of you can demonstrate, which on the MLO, you get the extreme posterior, right? Because that's what we're putting on there. The upper outer quadrant, you should be able to get that. There's no way you're going to get that on a CC view. The axillary tail, yes, we are going to get the axillary tail. And the medial and anterior tissues are the ones that are imaged poorly, because we tend to forget that as the paddle is coming down against the medial tissue, that it doesn't want to move. So if we don't have the patient leaning in properly and getting them on the detector right, we're not going to get those. And missing the anterior tissues, I say that it's not imaged properly. When you do an MLO on somebody who has a very large breast, and you get beautiful muscle, but don't get yourself the fold up there where I showed you near the axilla, because if the patient is heavy, it's already going to kill them to pull that breast out there and try to compress it when it's a nice thick breast. So your best bet is to do an upper and a lower MLO, and that's where you're going to get the anterior tissues of the breast imaged properly. But you can do it on an MLO if the patient isn't a very thick breast or real heavy breast, or they don't have all this accessory tissue or polymastia, which it is sometimes called. But this way you can make sure that you're removing those folds, but still getting a nice image, and you should be able to get the nipple in profile. And the biggest part about that is getting their hips in the right position, which I will talk about. So posterior lateral tissues usually run off the lateral aspect on the CC view, but it's imaged really well in the MLO. But when you're laying the patient on there for the MLO, make sure you don't have their ribs on there, because then you're going to have a problem with missing tissue there too, because it won't lay properly. So what are the expectations? Well, if we had to do one view, it would be the MLO view, because it visualized the maximum amount of breast tissue. It also gives you the extreme posterior and upper outer quadrant, and it shows you tissue, the axillary tail of the breast that's a lot of times missed on the CC view. And sometimes though, there's a distortion in the anterior, central, and medial breast tissue just because maybe that patient needed to have 2 images. We couldn't really keep it up there. So then the breast sort of falls down and the nipple angle points downward. And if that's the case, you're not spreading the tissue out and up like you should. So we can really see it good on the image. But that's the problem if we just had to choose one view to do for a person. The problem with the CC view, if we left that one off, is we're not really going to get all the medial tissue. So we don't want to lose any part of the breast because we want to find the cancers if there is one. What are deficiencies on the MLO? Well, the first one is always the incorrect muscle pattern. So we don't have the accurate amount of pectoralis muscle going to the level of the nipple or beyond. Sagging. This is where so many times, and when I was first taught, it was to lift the breast up and then lift the breast out. But the problem with that is it makes you get the fold in the crease of the breast, and the tissue will sag no matter what you do when you're lifting up all this breast tissue. Instead of pulling it straight out like you should, and then at the end, use the butt of your thumb and lift the nipple up, then you can visualize the tissue much better and it separates it. Poor visualization of the posterior tissue or the retroglandular fat, because if you don't get the patient on there just right and have her feet facing the machine, you're going to lose the retroglandular fat. You want to see that. Skin folds are bad, especially in the axilla. So you always want to, once you lay the breast on there, is to lift underneath it again. Not the patient. Tell them to try to relax there because they're going to want to help you and then they completely take their shoulder off. But you want to really make sure that you don't have the ribs and you can remove any folds. You want to start in the axilla and pull downward so that you're removing any folds. And a lot of people position the breast too high on the receptor. Now, ACR wants to see the breast tissue out and up, visualize the muscle right and everything. But when you're looking down at the inframammary fold, they really don't want more than about 2 inches from the edge of the breast where the IMF is, and you're pulling down on the skin to see some of the abdomen. They don't really want more than 2 inches there. But some patients have such a large breast, but they're short. Their chest is really short. But you don't want to clip off the upper part of the breast because a lot of times we do that and it looks so nice, but then you have half the film is nothing. So don't leave off getting right underneath the edge of the clavicle because that is breast tissue and it needs to be on there. So don't cut any portions of the breast off. And is it within that 1 cm when you're talking about the posterior nipple line? So what are the steps for the MLO? First, you want to have the detector parallel to the pectoralis muscles. So first you have to determine the angle. And when you go to determine the angle, I let the patient rest their hand on the detector, and then you only use your fingertips to get in the axilla. Yes, you have to put your hand up under their arm, and you're going to lift up on the muscle. You should be able to feel it and tell the difference. But if you do it for the whole complete breast, then you're not getting all of the muscle because the bottom part of the breast doesn't have the muscle. So we don't want to put that in there. So make sure, and then a lot of times you can just put your hand there if the patient, is basically average or maybe skinny. You'll be able to see it just by looking at it then. So you can see once we find where the muscle is that you can keep it where it stays still to put it on the machine. So you want to hang on to it and keep it and separate the muscles between the latissimus dorsi, the back, and then the front with the pectoralis. Now, you'll want to angle the muscle, the detector, somewhere between 30 and 60. A good average for patients with pendulous breasts is about 35. And patients who are really tall and thin, they really do better with at least 50 or 55. So, but I see a lot of techs want to do just 45, and that's the normal. But that's not always the way your muscle will lay on there beautiful. So you want to make sure keeping the pectoralis muscle and the breast tissue stabilized and pull it over onto the detector. The detector must be lower than the axilla. So when you start out with a CC, and remember, we've raised that detector up already. And so when you lift it up to do the breast tissue, it's going to be too high when you go to do the axilla. I'm sorry, but there's just no way you can keep it that same height that you had on the CC view, because we really raised it up to get the superior breast tissue. But now we need to lay the patient on there and relax the muscle. So you want to have it a little bit below, and you're going to take their arm and shoulder, pull it forward, because you want to really put the edge of the breast to about the center of the detector. So make sure that you have it lower, because if you don't, then the detector is too high. You're now going to get not just the pectoralis muscle, but the latissimus dorsi, and the muscle is going to be concave because there's no way to straighten that one up. And that hurts the patient when you put it in there like that. They'll have a big red spot behind their shoulder. The other thing is when you first start to lay the breast on there, you can have the feet facing you, because in a way it's better for them to sort of lean and rest on the breast, but the detector. But once they do, their feet must be turned toward the detector. Everything is about keeping all the breast tissue going that way. So the medial tissue, if those feet are turned at the least towards you or the other way, you're not going to get it all in there. So have them turn it towards the detector. But then you have to worry about whether or not they're in front of the detector. So the hips must be in front of the detector. And with that, you want to see an infomammary fold. But a lot of times, like on this one, you can see that there's this big hunk and fold. We actually sort of have the ribs on there. And the abdomen is behind it, because the patients, when they get all comfortable, they take a step, and the foot they always move and separate out wider is the side you're doing. So instead of staying more toward the center, they get a little more comfortable, they think, and they will push back, and then you've lost their IMF off of there. There's no way to get it on there. So you really do want to be able to keep the hips in front of it. So when you do, then it will open up your IMF. Now, the corner of the detector should be between the latissimus dorsi and the pectoralis muscle, which I was showing you how we sort of separate that to find the angle. Once you find the angle, and you see how much lower that detector is, but that's because the patient's going to lean towards the detector. I have them bend the knee of the side I'm doing, so when you kind of relax that side of your body, and I have them do it before I even start, then they do understand it better. So then you want to get between it. But what happens is when we get it too high and we get back behind the latissimus dorsi, man, that's painful. That really just jabs into them. So it's not comfortable in the least. It doesn't get the breast tissue on there very well. So we do want to double check and make sure that it's not behind latissimus dorsi. And that's what I'm talking about, bending the knee. That's the side I'm doing. If I'm doing the right side, I have them bend the right knee. But amazingly, while you're positioning, they will straighten that one and then bend the other knee, which of course totally throws the body off. And then they'll also take and move their foot back towards the detector, and they'll put their hips back behind there. So have them bend that knee, which helps to relax their body. Now, placing the breast on the detector. Some do it from behind, because for me, that was just always easier. I start with putting their shoulder on there and getting the breast tissue, but I don't worry about the front so much. And then other people will do it where they do it from the front and they scoop the breast up and put it on there. So do it whichever way works best for you. But I find for the heavier patients and, you know, counting my body type, that sometimes it's just too hard to do it that way. It's much easier to go from behind and come back to the front. So you want to place it on there. Now, this is what I was talking about. If you position the breast too high, or you're going to cut off the bottom of the breast. And amazingly, I see that where, like the infomammary fold, if it is on there, it's just this little fold and it's not even a half of an inch. That's not acceptable. And why in the world would you want to put it underneath the head of the humerus? You want it under the clavicle. So this one, they've just missed all that breast, because look at the size of that detector, and we hardly have any breast tissue over there. And you should be trying to center the breast. So those lines you see in the center where it's your photocell, you should be able to see that in the center part of the breast, not necessarily at the nipple, but at least above it. So if you get the breast too high, then look how much room is down here at the bottom. And that isn't acceptable either when you're talking about doing the patient's infomammary fold, because we don't want 4 or 5 inches of the abdomen and then clip off the upper part of the breast, the superior tissue, and the axilla. So we want to make sure that we're really centering it on there properly. But what's wrong with this image anyway? There's something that besides clipping the patient off. Never position with your thumb underneath the breast. That paddle's already coming down. As a matter of fact, it's already on her fingers. Now, how does that feel to the patient that we're compressing the breast, our fingers and thumb on the underside of the breast? It's not good. So you don't want to do that. But again, that one's positioned too high. The other one's positioned too low. We can't clip something off. So one of the things when you have put the patient on there and you've got your muscle where you want it, pull the shoulder slightly toward the C-arm and then rotate the head of the humerus anteriorly with the elbow relaxed. Now I always ask patients, have you had any surgeries on the breast or do you have problems with your shoulders? Because some people have frozen shoulders, they have issues with them. If that's the case, you can't do that. But if they can, I ask them, and I just barely raise their arm just a little bit, and I rotate the head of the humerus towards the machine, the C-arm, and then I have them bend their elbow and then just rest their hand on the side. I don't let them have the bar, ever. But it's really important to make sure that you have it on there because then you're going to get it widely superior instead of concave. So we really do want as much muscle on there as possible. But again, don't let the patient have any problems with it. Now, to immobilize the pectoralis muscle plus the anterior medial tissue. Now, as many times as you put the patient on up at the shoulder and you get the upper part of the breast on, you have beautiful muscle, you've pulled her shoulder over there really well. And then you come around to the front and the first thing they've done, if you're watching, is they've moved their shoulder to adjust how it feels. And chances are you could have a fold under there, but you don't want the patient to adjust. So I always go back around and reposition them again. And I tell them, I know this is going to be uncomfortable for a moment because I might have a fold there, but please let me get around to the front and make the adjustments myself, because when you remove your shoulder and adjust it, I lose muscle and the doctors are wanting to see as much as they can because we do want to see in the axilla as much as possible. And so we don't want to leave that breast tissue off. So really and truly try to pull, and then you're going to pull the breast tissue out with your whole hand and make it out. And then at the last minute, you'll do it up. But just trying to show you that we don't want to be, we want to get as much as we can and make that muscle widely superior. So the only tissue that's mobile, remember, is the lateral and the posterior tissue. So how are you going to get the medial tissue on there? You're going to have the patient turn their feet in and their hips must be in front of the detector. But they're going to sort of slouch in. So this sticking that booty out a little bit helps them bring that chest forward. Then that will help get the breast on there. Now, sometimes, even though you get a beautiful film and you get nice pectoralis muscle on these really thin patients, you'll get the latissimus dorsi too. But there's nothing wrong with it. You don't have to repeat it because you have it on there. But you just need to make sure, like the breast you can see on this images out and up. The nipple is pointing straight out, which it should be. It opened up the IMF. And you can see nice, beautiful muscle, and it is convex. And then you also have, like I said, the latissimus dorsi. So I kind of drew this little picture. I'm not an artist for sure. But when you're talking about muscle patterns, you really, truly want to see it to be convex. But I outlined the breast in red so that we know this one is concave because this one does not have enough breast tissue. And when you go to measure on the CC and the MLO to see if you have the right amount of breast tissue on there, you're not going to have it. There's no way. So you really want to have your muscle convex. These others are convex to the level of the nipple or below. I mean, men, you can do a nice job getting beautiful, beautiful muscle on them. Not as easy on women, but some are. But all in all, I mean, if you can get as much muscle as you can, really superior, widely superior, then have the muscle all the way or below the level of the nipple, that is good. So here we want the muscle pattern needs to be really widely superior with a convex anterior border to the level of the nipple or more. So unless you're going to get the shoulder almost, the breast itself in the line, getting it to the center of the detector, you're not going to get it all. So, and then you're never going to get all the medial tissue and be able to pull the patient in because the patient right now on this left image is leaning backwards a little bit. So when it goes to lay the paddle down, you're not going to get all the medial tissue, where the other patient is leaning towards the machine. But once we've laid it on there, you'll have to come back around and feel all the way from the axilla all the way down on the breast to make sure you don't have any folds. Watching the patient to make sure she's not taking your shoulder off. But this is where, at this very point, the patients have this tendency to take the step back so that their hips go behind the detector, which unfortunately by then you're never going to get the IMF and you're not going to have it open. So really important to keep their hips in front. So here's a good picture, except there is a little bit of a fold up in the axilla. And it could be just the vein coming down there, I don't know. But really, I would think it might be a fold, just have to see other images for this patient. But she's nice and thin, so we only got a small inframammary fold, but it is open and the breast is out. So when we look at this next one, there we don't even have but about a ½ an inch for the inframammary fold, which they want to see more. And I'm happy that it's up here on the top and we haven't cut any tissue off. But was this done on the larger paddle, or was it done on the small to give us a smaller image? So that may be why this one looks like it's cut off down here at the bottom, because it's on the smaller detector. But your muscles are nice, low to the level of the nipple or below, and nice convex borders. But when you get concave, then there is no way you're going to measure from that nipple to the back of that muscle and get a measurement that will fit on the CC view. And then the inframammary fold, her hips are slightly in front of the detector because it's not a horrible fold, but this is where you need to reach underneath the detector and just with the edge of your fingers and pull her forward, and at the same time have your other hand on her hips and pull her towards you. So you're slightly lifting her off of the detector right here on the inframammary fold to just be able to try to open that up a little bit better. All right, so here we have a concave muscle and we have more of a convex, a little bit of a convex, but a good inframammary fold, the nipples are out like they should be, the tissue is out and up. And so when you go to measure these, they're not going to measure the same because there's not very much muscle over here on the right. And I'm not sure what happens to the patient, that it's sometimes just the patient. So the convex border ain't to the level of the nipple, so it won't end up measuring and meeting up with the CC view. And then we can see where the nipple, the muscle in this one comes down to the level of the nipple. So positioning dilemmas on the MLO. Well, if the pectoralis muscle doesn't reach the nipple line, you need to rotate the detector parallel to the muscle. So maybe your angle is not right. So you might need to adjust a little bit. Make sure that the arm isn't rotated or elevated or slightly abducted when assessing the angle of the muscle. So you really, like I said, use your fingertips in the underarm so that you can really feel that muscle and separate the two between the latissimus dorsi and the pectoralis muscle. So when you move that muscle anterior and medial, make sure your hand is behind the breast and the muscle with your fingers in the underarm or the axilla. Don't sling the breast on there. So making sure you really do have the muscle. So smooth out the skin between the breast and the detector after immobilization. So, you know, like I said, it's so nice. The arm is over, it's to the center of the detector. Now we've got to make sure that we don't have any folds, and we want to put our hands starting at the top, but then you're going to go completely under the breast. And this is sort of a side view trying to show you how we're positioning or pulling the breast down. And then you want to make sure that when you get down to the bottom that you're hanging onto the patient's hips and turning her towards the machine. So you have to do that. But the middle image there, like the detectors, it's just way too high. You see how her arm is completely up? The problem with that is don't start doing that if you don't have the shoulder immobilized and the muscle in front of the detector. So check for those folds. And then again, check and make sure that the ribs aren't on there. That's when I do that thing from the top where I start with the underarm and I come on down, but I will a lot of times reach behind the patient to the back, and then you can tell that you can feel the edge of the ribs on the detector. If that's the case, I tell the patient, don't move, but I'm slightly going to just lift up on her, just slightly with both of my hands. It's not going to move her very much, but it should get the ribs off of the detector. And then you're pulling the hips more forward. So you do want to do that check and make sure you don't have the ribs. Also, let the detector be the one that keeps the muscle and the tissue immobilized. That means You're laying down with the patient on the detector and basically just have her lay back as if she's relaxing somewhere. You want to be right below the clavicle. And again, make sure that you don't have any folds, but be careful that you're not pulling the breasts up so much that you get this fold in the breast, the upper breast, especially around the curve. So double check before you even start compression that you don't have any folds. And no gap between the patient and the detector. So there is a thing called a 3-finger check that some of us use. But again, if you look at this image on the left where the 3 fingers are, nothing personal, but that underarm is not going to be at the edge of the detector. The shoulder is way too high, so that's going to be a straight muscle. This is where the patient needs to lean. But once she gets on there, you've pulled the shoulder forward and relaxed her, just follow it down and make sure you still don't have her ribs on there. Try to get the nipple in profile. And this is the view that is the best to get the muscle, the nipple in profile. It works on almost, at least probably 70% of the patients, but it isn't going to work on everybody. And it's not going to work on anybody who's the nipple gets clipped off just past the white line. If that's the case, and you see that's going to happen when you're trying to position the patient, then make sure that you don't get yourself a fold up in the upper part of the breast before the axilla. And where they sometimes have folds, and make sure that if you have to, then just pull the breast out, pull the patient in. But if you're going to clip off the nipple anyway, you're going to have to take an anterior part of the breast. So try to get a good infomammary fold, even if you don't get the compression at the nipple. So once you do get the patient on there, and you can see where the photocells are on here, but you can see where it's centered to the nipple. Above it just a little bit, but it's center of the breast. And then you're going to make sure that you have the infomammary fold on here, but where you can see where my fingers are, the infomammary fold isn't even on there. So the problem with that is we may have to need to go underneath. But most of the time, if you've got their hips in front, you should be able to take your finger and thumb and pull down on the infomammary fold. So check that the hips are in front, and then make sure you don't have any air gaps, because some people they suck in their tummy because they don't want you getting it on there. We don't want them to suck in their abdomen, because abdomen and the breast connect, and we need to be able to see it. I always explain it to patients. They do a much better job. So make sure you don't have that going either. You want to have a good infomammary fold. Obviously, my little angle is not right, but once you get her on there and you pull her in and make sure she's in front of the detector, then you should be able to get a good infomammary fold. But I don't know if you can tell that just above my thumb, it looks like it's almost like a little crease or a little fold, sort of right there when you're pulling the breast out. Sometimes lifting the other breast up keeps you from having that itsy bitsy fold that sometimes happens along the chest wall. So the breast goes out with your hand, whole entire hand, thumb as one. And then when you get close to the bottom where you want to pull the nipple up, then you're going to lift the nipple and have the butt of your thumb be the part that lifts it up. The rest of the breast should already be on there and should be compressed. So the hips are in front of the detector. You'll get a perfect IMF, and just make sure that as you're compressing that you don't lift the breast up like this. You need to do that only at the end, but this is trying to show you how it opens it up when you finally pull at the nipple and it opens up the infomammary fold. Because when the upper breast, if you're just trying to lift it all, it's going to probably fall and then cause you to have the breast sagging down and the nipple down. So you really want to be out and then up, which is not the way I was originally taught, but we can all learn. So when you start your compression, have one hand next to her sternum. One, so that you don't hit her, but two, so that you can make sure that you're not losing any breast tissue. It gives you that chance, like I have my hand draped right there, but I can take my arm and move her other shoulder forward so that I can keep that medial tissue on the plate. So make sure that you're just below the clavicle. You're not below the head of the humerus, because you're not getting all the muscle. If it seems you're going to hit the sternum, then slightly push the patient back just for that 1 second to keep from hitting it, and then pull and move past it at that point, because sometimes it's just one area of the ribs or the sternum, and then you pull the patient back in as soon as you get past the sternum and continue compressing. At this point too, it's a good thing about having the patient breathe, because when you're starting to bring this down, have the patient take in this time and tell them, this time I want you taking a deep breath before you're compressing. Then as they compress and they slowly let the breath out. When they do, you bring the compression paddle down and then you should be able to get good compression even on the anterior breast, and it'll help you get past those ribs. But if you don't have good anterior compression on the breast, then you're missing separating the tissues, so you do need to do a lower. So that breathing technique, have them take in that deep breath and then blow it all the way out while you're compressing, not in one blow like you're exercising, but instead you take in that deep breath and then you want to slowly blow the breath out as I'm compressing. And then I just tell the patients to breathe normal through their nose. No big breaths, don't stop breathing. This way they can still have air moving. This will relax the chest, of course, and give you better access to the posterior medial tissue. And it'll be much more effective than just saying relax, which patients don't like that word very much, but there's so many things you want them to relax. But the breathing thing will help them relax and they just don't realize it. So that is a plus for you, and you'll see a big difference if you ever try it. Make sure the hips are in front of the detector. Compression should almost be taut. So run your hand along the patient's side at the IMF where it comes in contact with the detector and pull the patient towards you so that her hips are in front of the detector if they're not. And with your oops, I don't know what that did. With your index finger and thumb, pull down on the IMF to remove any folds and open it up. So this patient has moved herself back a little bit because you can't see, I can't get my fingers there. So I'm going to have to pull her a little bit towards me. This is not a total taut compression, for goodness sakes, because you're going to hurt the patient if you're trying to move her when she's compressed as tight as it can possibly be. So you may have to lift the compression paddle up just a hair, and then pull her towards you and get her, and then straighten out the IMF. And when you do that, you should be able to take the finger and index finger and the thumb and pull down and get a beautiful IMF. So here's where you can see, it looks pretty good when you look at it up there, maybe a little bit of a fold. And we're doing this way high on the detector just to try to show you this part. But really and truly, we actually have the ribs on there. So one of the things you can do when you have most of it on there is you can slightly use your finger and push that part back without taking her off of there. And a lot of times it'll straighten it up because it's just caught it right there. But if the hips are in front, then you can use your finger to remove the fold rather than going underneath her. But you can tell over on this first image how far down the abdomen is in front of the detector. So it just has a slight fold at the ribs right at the IMF. So if the hips are in front of you, then you can use your finger to remove it, but you want a beautiful IMF. Now, so we're going to look at some MLOs now. And what we see is some retroglandular fat on this one, the white part where you're back almost to the IMF. So this is more than likely a skinny patient. You can also see the latissimus dorsi at the top. So a lot of times you can't really pull the patient on more than that, but you do have some retroglandular fat back behind there. But when it comes back for another year, look how much more they really do have the retroglandular fat, and they worked hard at trying to get the inframammary fold on there, but this time they didn't do that double check to make sure they didn't have the ribs, because that is part of her skin from the ribs on the inframammary fold. But they also got a fold up on the muscle too. So, you really want to compress the breasts and see it. I think the compression probably looks a little better on the one on the left than the right. You can see through the tissue a little bit better, but they didn't get all of the posterior tissue. So without the hips in front, you're not going to get posterior medial tissue on there at all. And here's one where we've used the wrong size paddle again. I say that because I'm sorry, the inframammary fold is completely just at the edge of where the breast and the fold, the two abdomen parts that are on there, because the hips, you've got this black space in front and you don't even have the inframammary fold on there. So there's no way you can open it up if their hips are back behind the plate. So make sure that they have them on there and use the right size image. Either come down a little bit more from the superior on this patient, just to show your little inch down there of the inframammary fold, but don't sacrifice getting all the tissue you want on there, because with ACR, you need to see that 1 inch at least on the inframammary fold. And you can't see it there, nor can the doctors. And if there was a cancer there, you wouldn't see it. So really nice muscle though, of course, way below the level of the nipple, but just make sure you pull down and open it up. So have their patients raise their head up and look towards their shoulder, because so many of them will get their chin in there, or like their head, I don't know what happens. Their you're sitting there doing it, and the patient is slowly letting their head fall down. And I can see it and say, oh, keep the head up, but they don't really listen. Check that no earrings or glasses are going to be in the image, or chins. Tell the patient not to take in this deep breath due to the motion once you get her positioned. So remember, we've taken a breath, let it out, and then I tell the patient, just breathe through your nose. And this is a final compression by checking tautness in the IMF. So the corner of the compression paddle should just skim the clavicle. We don't want to be on it, but we should be right below it. Move the opposite breast out of the image field without taking this other one, because so many of them take and scoop that breast and pull the whole thing, and now you've pulled your medial tissue out. Open up your IMF so that it's really open, and then have your nipple and profile. So that makes a beautiful image. So you really truly want to make sure that you're getting it all, but if possible, don't get this much. I mean, this is right below the clavicle, but this is probably the large paddle, so maybe she should have been on the smaller one. Dilemmas on the MLO. Well, first, the muscle is not convex. So if you don't move the muscle anterior and medially and keep your hand against the rib cage, so that when you're putting her on the detector, you know you're putting the muscle, you're not putting something else or keeping part of it off. Make sure the head of the humerus is really near the center of the receptor. So you've pulled her over. Hand against the rib cage, make sure you don't have any ribs on the detector. That's where you got to do that check. Once you lay them on there, you think you got the muscle, you want to feel that you have the muscle. You want to pull down on the breast tissue, but go all the way down, because if we're going to get a fold, it'll happen in the axilla for sure, and somewhere sometimes in between where the ribs are. So just make sure you immobilize the muscle and the breast against the edge of the detector. This is sometimes where, I mean, you just got to double check that you just don't have ribs on there. Now, when you have glandular tissue that's running off or is missing because the patient didn't get turned in enough, she didn't lean forward enough, we didn't pull her on there well enough, there's all sorts of reasons. So first, make sure your angle is correct, because if you have too high of an angle or too low, then you're not going to get the muscle right. So you do want to double check. Make sure the breast tissue is that you move the anterior and medial breast tissue, pull them forward, meaning take the back of them and turn them toward the detector so that we can get all that tissue. We don't want to lose the medial tissue, and that's the best place to lose it. And you will lose the glandular tissue or the fat. Place the immobilized breast against the edge of the detector while you're moving your hand out, and then make sure the IMF is in front of the detector. This image, the bad news is that the IMF is really clipped off at the bottom. Do you see that inch that they like to see? No. So either we've got the wrong size paddle on there, or we can move down just a little bit, which we can, because I think it looks very high, and bring it down just a little bit so that we can actually have the breast centered on there better and get a good IMF. And make sure that your hand makes the breast come in contact with the detector, because if you've got ribs or a hunk and fold back there, when you go to compress them, it's going to hurt them, and then they're not going to be happy about having another one taken. What if the superior aspect of the pectoralis muscle is narrow? Well, a lot of patients, I mean, you get nice muscle all the way down to the level of the nipple, but it's real skinny. So you can adjust the height of the detector to a relaxed axilla, meaning that you might need to bring the detector down a little bit, because like I said, it should come down a little bit from the CC anyway. And position the corner of the detector posterior to the axilla, but in front of the latissimus dorsi and in front of the pectoralis muscle. Stretch the arm over the top of the detector, moving the head toward the center. So, and do that 3-finger check where, like at least I hang on to them from the back, because one, I don't want them pulling themselves off of the detector, which they will, or they're going to move their shoulder anyway. But you want to double check that you don't have the ribs against them, that you've just got the muscle. And don't let your fingers go past the chest wall edge of the detector. So, make sure that you've got her on there, but you're just coming right to the edge of the detector to check and make sure you have her on there. And the shoulders really need to be relaxed, but I'm not kidding you. Some of them can get them all the way up to their ears. So this is where I just press on the shoulder lightly and tell them, really just let that muscle go. And if at all, like make your shoulder just a little bit relaxed. But some people are so nervous, they can't relax their shoulders. And if their arms should be relaxed with their elbow slightly flexed, behind the detector where I showed you that you lay it there, But remind the patients if there's a place to grip, they will. And don't do death grips because you're just tightening everything when your hand is gripping that tight. So why is getting the IMF important? I mean, like we're really focusing on this and why should we even worry about it? You don't see much of anything ever happen there, but guess what? This patient has a cancer right there. And we got a hunk and fold and didn't see behind it, but on spots, which is really well, I mean, they really pulled her over and pushed her in, and we even got retroglandular fat back behind there. But you can see how spiculated this cancer is. So we don't want that to happen to a patient. And here's a couple more examples where, again, cancer is at the IMF, and that's frustrating. So, and this image on the right, it could have come down a little bit more, but this was just an anterior view trying to get back there, but the patient says she feels something there. Don't leave it off in the room. And these have waited till it's gotten a little bit bigger, but what if it was just a very tiny cancer that you just don't even see at all because you didn't get it on there? So we really truly want to see. So skin folds at the IMF prevent us from seeing that area very well. So you would really like to have the one on the right, that much of the tissue on there. You really do. But get a good infomammary fold with it open and separated. But the patient's hips could have been, and body turned just a little more toward the detector on the left so that you could have gotten a little bit more of the posterior tissue. And then you get really good IMFs. So you really want to have that. And if at all possible, have your nipples standing up and out, basically. So you need to, on the right side here, you can see the breast tissue has been pulled out and the nipple is nice and straight across there. But the ones on the left, the nipple is slightly sagging, which means you see a little more motion and it doesn't separate the tissues as well. So you do want the nipple in profile. And again, nice, beautiful pictures where the muscle is down to the level. It's not a real wide one, but look how skinny they are up in the shoulder. That means that this patient probably has breasts without very much fat or a lot of skin up there. But again, the nipples are pointing straight out, a good separation of the breast tissue. So very good. And again, another one where we can see the IMF and we want the nipple out. But of course, when we don't turn, the nipple isn't even in profile. But this one, I think if we had gotten her infomammary fold and the hips in front of the detector, the nipple would have been in profile. But again, the breast needs to come out because you can see the tissue on this right picture that it is leaning down. Another one where we didn't get the IMF and we have a good old camel nose, which is not going to separate the breast tissue to be able to see it any better. So when the patient comes back, you really want to separate the tissue. Which one would you want your radiologist to look at and say you might or might not have cancer? So don't leave it off. It's so, so important. And the breast does need to be out. This one has a slight fold in the IMF because the nipple is, everything's pointing downward. So they did more of just raising the whole breast. And then at the time when you're trying to compress all of that in that direction, you get a fold up here in the breast near the axilla and one in the axilla. But you don't have good compression or separation because the breast has fallen down onto the IMF. So don't want that. Have the patient still, there's a fold in the IMF on this view, but the breast tissue is out where you can really see through the breast tissue so much better, and we removed the fold. But we didn't do a double check and make sure that, you know, with the finger, index finger and the thumb that we pulled down on this. So the hips are slightly behind that detector, not all the way, but slightly. And then these are just, I put this in here because the top is just unbelievable. There is no muscle. Now, whether the patient let the person do it, I don't know. But, you know, she's a lot of breast. And this one, if it was going to be for the anterior compression, then forget about the upper. But there's no IMFs. They didn't get the muscle on there very well. So this one needs to have it completely taken over. But these are images that were sent through. Another one where it's funny, you get a lot more IMF on one side than the cleavage than you do on the other side, but the nipple has gone under on the left CC view and the right, it's where it should be. So where have we got to get the nipple in profile? Well, we're going to have to get it in profile on the MLO, on the left MLO, but we don't want to lose all this superior tissue, posterior tissue, but at the same time, we really need to have good compression. So sort of let the breast fall, not a lot because you have good compression, but The breasts will just have to fall and the nipples are pointing more downwards so that you can do anterior breasts. But again, the sad news is this one never got the nipple in profile. So another view either has to be taken to put it in there, or when they were busy doing the patient, just forgot to look at the nipple and see that it was not in profile. And we don't have much of an IMF on the right, and the nipple, it just wasn't pulled over enough as well. It doesn't have enough contrast or compression. This is the one I showed you at first, when you can see that there is so much retroglandular fat on the right side and there wasn't any on the left side. So I hate to say it, that their breasts are probably pretty similar. So, you know, we've already seen that, yes, there is more tissue to be had, but look at the nipple pointing medially on the left. So we didn't get the other breasts up there very well, even though we've got a good separation of the tissue. But this nipple may point that way a little bit because they did get good lateral tissue. And on the other one, the nipple really is in the center of the breast, but we didn't get the lateral tissue on there. And then the MLOs, seeing those, of course, we've missed a lot on the left MLO. There's no retroglandular fat. There's no infomammary fold. The muscle is really pretty good. But we want to try to have the breasts out and up so that we can have better compression. So when the patient came back the next year, then we're seeing where we did get the cleavage view on the CC, where you can see that white, but we didn't get the other breast. It wouldn't either stay up there or something, but we have both of the nipples centered. We have good separation of the tissue and retroglandular fat behind even the lateral tissue. So that's good. If you don't get it though, you should get it on the other. But here, the patient's not very much muscle. The text did basically about the same, and it wasn't the same one. But we did get retroglandular fat, meaning that they turned that patient more toward the detector and got her hips in front so that we could see that retroglandular fat. So looking at them, just to compare them, to look at them together, which one do you want it to be, you or your mother or your sister or someone that you know? So we really do want to see everything and don't leave things off in the room. All right, and this one, I don't know, the image was turned in this way and the patient has hardly any muscle and a terrible fold. And then the next year, they got great muscle, but that's horrible fold. So either it's a vein or something running through there, I don't know. But it was sent in that way. So I don't know if there was a problem with the patient or we just didn't go and do the check where we went all the way from underneath the axilla down and pulling down on the breast. But we also don't have the infomammary fold all the way, but good muscle on the next year. Here's where I talk about, you know, watch that fold in the upper part of the breast near the axilla, because a lot of people who have that polymastia or accessory breast tissue has a lot, but you want to pull the breast tissue out. And sometimes even after you do that and you pull up, you may still have that fold. So go up to the top and see if you can't pull it out. If not, just do an upper and a lower. When you're starting to position them that way before you even compress them, go ahead and look at it. And then just open that up so that they can see it, and then do a lower so that you can see the anterior breast with the nipple out like it should be and in profile. So this one does have a fold over here on the right image, right in the middle. There's a little bit of a skin fold. So always make sure you do your hand where you go underneath and make sure there isn't one. And then again, the left MLO on this side does not have any infomammary fold. So tissue has been missed. The nipple is pointing straight down, so the breast wasn't lifted out and then up at the end. And then again, we have that fold over there in the underarm. All right, so here's another one, pectoralis muscle. Bad news about the folds and the cleavage. The nipples aren't in profile. So, but then we got great pectoralis muscle on the left, and the nipples are in profile, and the breast tissue is out. So we got good infomammary folds. So this one is fine. Just up on the right, try to make sure that you lift that up and try to remove that fold if possible where the accessory breast tissue is. Another one, just to show the same patient, but the next year. And then this one I showed you at the very beginning, so I'm not really going to discuss it, but it's just nice muscle, really at the same level, and the nipples are out, just not as much of the retroglandular fat on the right MLO, because You can see how open it is on the left, and the right is just a small one. Not that it's not open, but look at the tissue we're missing if we got that on the left. So for the CC view, we're going to talk about the posterior nipple line. So the CC view, it's the distance from the nipple skin junction to the back of the image, not to the where the nipple points all the way out. You're just doing it to the nipple line and all the way back to the chest wall. It doesn't matter if you have muscle or not. It's all the way back to the chest wall because the muscle presents itself different on the CC than it does on the MLO. So you don't want to just go back to the level of the muscle because it isn't gotten on most of the images for the CC views. And the second thing is that the rule is it goes back to the level of the chest right against the chest wall. So in the MLO though, it's the distance from the nipple skin junction to the pectoralis muscle or the back of the image, whichever comes first. So if the muscle doesn't come down there, then it's to the back of the image at a slight angle. And so we draw the lines, and I'll show you the pictures here. So I tried to make them where you can see them better because this is an old picture and I can't find a new one. And I'm really not that good at drawing, but I did draw the line, and the one up here on the top for the CC should go all the way to the nipple line, but I tried moving that one over and over and it would go past it or below it, but it would never go to it. But then you can see on the left CC that it is to the skin junction. That's where we're talking about. So on the MLOs, the same thing. So if the muscle doesn't come down enough and you have this angle, you measure, and then it's to wherever the skin line is or if the muscle is there. So don't measure out to the end of the nipple. So here's some measurements. The posterior nipple line on the CC view, this measures 99.9 millimeters, and I changed it to centimeters because that's what we're talking about, and it comes out to 10. This one measures to 103.4 millimeter, but it measures out to 10.3. Are we within that 1 cm? Yes, because if that one was 10 cm on the CC view, you can go all the way to 11 cm and still be there. That's at 1 cm. But it only went 0.3. So yes, this one's like right on. Here's another one. So this one measures 95.8 millimeter, but that turns into 9.6 centimeters. And 110.6 millimeters, again, that turns out to be 11, basically 0.0 or 0.1. So we're measuring back to the muscle. And does this one measure 9.6 to 11? How many know or can tell me the answer? No, it doesn't match, because if it's going to be 1 cm, what will it be? 10.6? Yes. So definitely they don't match. Another one, 88 millimeters or 8.8 cm. And then on this one, it's 93.1 millimeters or 9.3 cm. So does it match? Absolutely, because it could go to 9.8, or this one could be the CC at 8.3. It would all still meet. So another one at 8.5 cm, and the left one is 8.5, the right one is 8.3. So we're going to see the two CCs, and then we're going to see the MLO. The MLO is 9.1 on the right and 9.9 on the left. But does that match up with the CC view? So now we're going to put, the CC view, that was 8.3, and the right MLO was 9.1. Does it match? Yes, because it can, remember, go to 9.3. So yeah, that one matches up. All right, and how about the left side? So the left was 8.5 centimeters, and this one points 9.9. So we're missing some tissue somewhere, because the only highest that this could go would be 9.5. All right, so it doesn't measure up on that one. So we either need to try to get more on the CC view, or the angle on this right MLO though might be just a little bit high. So chances are it probably really does come out within the lines. But when you're measuring, you want to have it's not really per se 45 degrees, but somewhere about between, I don't know, 40 and 45 degrees, you figure it out, but pull it down to the level of the muscle. Here's another CC, 9.0, and the other one is 8.2. The MLO is 8.6 on the right and 7.7 on the left. And man, this one has some muscle. It goes all the way down. Of course, the IMF is not the most beautiful, but let's see, do they match up? So 9.0 to 8.6, yep, because wow, look at that muscle, but it does meet. They're just a few centimeters off. The other one that measures out to 8.2, and then this one goes to 7.7, does it meet? Yes, they even got more muscle on this one. It's a much more convex border. So yes, they absolutely meet. So then we have 100, and I don't know why I wrote 102.3, but it's 10.2. And then this one, it was 103.4, which is 10.3. So this is from 1 year to the next. So they have stayed within the same area. Much better muscle on this one on the right side, but at the same time, they still have good muscle and meats for the other one. So did we get enough pectoralis muscle and the correct pattern on the MLO? Can you see the retroglandular fat? Does the posterior nipple line come within 1 cm of the CC view? Is there sagging? You've got to keep the tissue out so that it spreads and separates the tissue. Are there any skin folds? If there is, you need to take that image over. And is the breast centered on the receptor? You would like to have it centered the breast, not the nipple, because it's usually, if it's going to center on the MLO, is above the nipple. And then you should have about 1 inch or 2 for the inframammary fold. But don't clip off the top to be able to get that, and don't use the wrong size detector. Can you visualize the entire breast, that you've cut nothing off and you've left nothing off? So you want your superior tissue, the axillary tail, you want all that to be on the tissue, the breast image, but have you imaged it all and you didn't clip it anywhere on the top or the bottom? So no matter what, we got to tailor the exam. So remember, those difficult positioning or body types, the different ones, you must attempt to image the entire breast. So if you don't put your skills to use, it's not going to happen. So where is Miss ACR? Well, it's kind of hard to tell. Is this Miss ACR or is this? Well, definitely the one on the right. If you've got to send more than 4 images, they're not definitely Miss ACR. But everybody you want to make your images the best you can for ACR. Use the anatomical landmarks on the mammogram to determine if you've imaged it all. Don't rely on the image alone to indicate missing tissue. And be attentive during positioning to the area that escapes compression or is inadequately compressed. And you can tell that by looking how separated it is, and capture your missing tissue no matter what. So don't stress out. If you need to do more views, do it. Don't get an attitude and give yourself permission when you've had a long day and it's been a bad day at that to do a bad job. So remember, no matter how many mammograms you've done that day, your patient's receiving her first and only mammogram of the year, more than likely, unless she's a breast cancer patient. Treat her as she's someone special. Someone loves her. She's someone's somebody. So try doing every patient as if they were you. So bad mammography can't be perceived without the knowledge of good mammography. So as you can tell, its accuracy is easy to read on any scale. You don't want to have leftover tissue that is not on the image. So follow the ACR standards for positioning to produce studies that are very compatible and comparable to the previous images, but don't leave the cancer in the room. All right, enough already. So any questions?